So I'm Jackie Pottle, and I'm Cancer AHP lead in Betsy Cadwallader. And my role has very much been about looking at service development for patients, any patients in the cancer division, and look at how therapists can support them in a really meaningful way. So I'll hand over to Jeanne.
I'm Jeanne Dorr, and I'm a clinical specialist occupational therapist in the palliative care team, and I've been involved in the cancer-related fatigue service now for almost 12 months.
So in terms of the challenges that patients with cancer face regarding fatigue, when I started in post, I started by reviewing what were the patient's concerns, and cancer-related fatigue was highlighted as the problem that all patients were facing across every tumour site and at different stages. So it was a problem that was kind of when people were starting their treatment, people going through treatment, or people had finished their treatment. Their highest rated concern was often fatigue. So we started by so myself and a colleague, Lisa Heaton Brown, started with a survey to healthcare professionals to see what were they doing to actually support patients to manage this symptom, because it was obviously the thing that mattered most to patients. So that was our starting point. It was about, finding out what was the most prevalent problem for the patient, and then what were the healthcare professionals doing about it. So it very clearly kind of showed to us that cancer-related fatigue really mattered to the patient. And the results of the healthcare professional survey was that healthcare professionals had mixed levels of awareness, but what they really didn't have was the time to actually implement evidence-based practice, or didn't really have the time or the knowledge to actually provide support in a really meaningful way. So for healthcare professionals, those that were aware of it wanted to provide support, but lacked time and capacity to be able to do that. So that was very much the starting point of our service. Well, I was the one that had initially heard of I'd become aware of Video Group Clinic as a means of providing support during the pandemic. I was myself alongside Lisa Heaton Brown, we're both very keen that the intervention that we offered was going to be in a group format rather than just one-to-one. So although we do offer some one-to-one interventions, we were very aware that the peer support element would be critical in helping people to realise, A, that they're not alone managing fatigue, but also to learn from each other. And that although as professionals we have a certain level of knowledge, I think we very much felt that they would learn as much from each other as they would from us. And we really wanted kind of an interactive group format to actually provide that. And I think if it hadn't been for the pandemic, we might have tried to do it, face to face initially, but we really didn't have any choice. So this for us, it was very timely. It gave us a chance to actually trial a format that we had never used before to see if it would meet our patients' needs. So our recruitment process initially was challenging. This was a brand new service, so we kind of had to promote the actual and highlight the fact that there was a need for patients to have support with fatigue. Rather than just being signposts to information, it was about sharing with all, as wide as we could across the health board, that this service was available. So in parallel with the Video Group clinics, we were actually running education sessions. So we started by doing like a workshop, and then we were doing some briefer education sessions on cancer-related fatigue. If I'm honest, at the beginning, we were worried that we were going to get flooded with referrals, but we were surprised to find that we didn't get a lot of referrals. There was one or two, but they were trickling in. And that highlighted to us that we really did need to have education going on to highlight, and remind people to be asking about cancer-related fatigue and then signposting them to us. We had originally developed a referral form, which we asked particularly clinical nurse specialists to fill in. And part of that was because we had some kind of clinical elements that we wanted to address. We wanted to make sure reversible causes of fatigue were addressed. However, we realised that, we weren't getting an appropriate response. Understandably, the clinical nurse specialists are incredibly busy, and the medical team, they were not filling in the referral form. So we went back to our cancer patient forum, and we had discussions with them about how acceptable would it be to have a self-referral mechanism. And they felt that would be a really good idea. And they supported us in designing the actual form, kind of made comments on it, and we had support from IT. So then we created a self-referral form, and I've then promoted that people can kind of do it online. They can do it's like a smart survey. They can use a QR code and kind of click much easier onto that, or they could do postal, that they can actually fill it out and then put it in the post. And we have heavily promoted that in that it's gone to all the CNSs, and we've encouraged them to put it in like the patient's folders, so that the patients then have the information and it's up on notice boards, so that if patients see it, they can then self-refer. And from that, we have had an increase in referrals. We initially decided that we would offer a hybrid model of video group clinics, in that we wanted to give some information, but at the same time we wanted to keep very much an interactive element. So we decided at the beginning to do our first session, was actually having a consultation with the patients about how fatigue was for them. And the initial one was a bit more of a discussion. And then our second session was purely an education session. And then the third one was actually picking up some of the themes. But we have adapted that, but perhaps I'll explain that in a few moments. We've actually changed the way we've put the content in now. Jeanne, I don't know if you're able to pick up and explain that a little bit, in that we've moved some of the information about fatigue into the first session. So if I hand over to you, Jeanne, thank you.
Yeah, in the first session, we obviously have the facilitator who introduces the group, and we'll look at the discussion board as well, with the patients attending, which covers the concerns that they have had. They've discussed in a previous telephone call with us, and then the clinician would then discuss or present about cancer-related fatigue, what it is, and then there would be a discussion in the middle of that with the patients, for them to share their experiences within the group, and any sort of tips or techniques that they're using at the moment that they found work and what doesn't work. And then at the end of that, the clinician will actually ask them if they do have any other further concerns, and they're discussed. And then the facilitator will then set a goal with each patient for the following week. The next session, the facilitator will review the goal from the previous week with them at the beginning of the session, see how they have got on throughout the week, if any positives or any further concerns. And then that one was more of an educational session, like Jackie said. It would give a lot of information initially, but we have now decided to take a little bit of that around the pacing and the prioritising of goals and activities into the first session, which would also be a bit more of a guide to their goal setting as well for that week. And then again, we will set goals with them on the second week, ready for the third session, which is another discussion session where we've discussed what's gone on previously and covering any other further topics that they have raised. And again, we then do set another goal with them for the following week, which we then do follow up with a follow-up telephone call to review and hopefully set them on their way and complete any outcome measures with them as well then.
So in terms of education, the education was aimed at the healthcare professionals to increase their awareness about asking patients about their fatigue, about what fatigue was and how it impacted on them, and how the patients themselves felt they could manage the fatigue. And if there was areas of, if the patients were reporting back that they were concerned and that they were struggling, to then refer them to our service. And we went over the fact that we've developed a SharePoint site and that we were offering these patient support, ranging from some just needed telephone call support, but we wanted to make sure that they were offered the option of joining the video group clinics as a way of having interactive support.
So the video group clinics would last for approximately 90 minutes and as they are run over 3 consecutive weeks. We would normally have around 4 to 6 patients attending. We did initially say that we could take about 8 to 10, but because of the I suppose the uptake of patients wanting to attend, the most would have been about 6 that would have attended. Within the team, both myself, I'm an occupational therapist, and another occupational therapist, Ellen Greer, we will alternate between facilitating and being the clinician on the first and third session. And then within the second session, the clinical consultant psychologist, Lisa Heaton Brown, would attend as the clinician, and either myself or Ellen would be the facilitator. Having a non-clinical facilitator, we did consider this initially. However, because of some of the topics that were coming up with the concerns that were raised, we felt that it was more appropriate for a qualified clinician to also facilitate the video group clinics, being able to signpost adequately to other services, or also to offer the support that was needed. There was quite a bit of psychological support that was needed throughout each of the sessions.
In terms of the impact of using this model, for us, it's difficult to kind of say what was different because there wasn't a service before this. Nothing was offered really in terms of cancer-related fatigue apart from signposting people to kind of online resources. So for us, it was a kind of a whole new service, of which we have, kind of adapted the service as we've gone along, really, in that I think it was a bit of gut instinct, if you like, in that we felt that there was a need for a mixture of education and interaction. And I think what we have found over the 3 sessions is that it feels more comfortable to have a mixture of both the education and the interaction, to a degree, rather than keeping them really boxed off and quite separate. And part of that is that we've actually selected to use a patient recorded outcome measure as the basis, in that actually identifies what somebody's concerns are. So we then use that throughout each the 3 sessions to guide the content that we're going to be discussing, and to complete the goal setting. So our choice of the use of a specific kind of patient-recorded outcome measure has probably influenced the way that we've run the sessions. And in terms of efficiency, what it has meant is that we've been able to come together as clinicians to do this. And I think if we weren't using a video group clinic, it would perhaps be harder to get the clinicians together at the specified times. Whereas doing it remotely means that we can make sure that that's in the calendar, and that we can plan ahead over the next few, sessions, so that we know when the person that's going to be giving a little bit more of the education aspect, which tends to be our psychologist, we can make sure that that's scheduled into her calendar, and she only has to join, kind of for the middle session out of 3. So that isn't as time consuming for her. And in terms of the 2 occupational therapists running the sessions, if I'm honest, it may even be slightly more time consuming, as it needs the 3, it needs both of them to attend, certainly the first and the third. But if we were doing it face to face, we would have to have both of them there as well. So I would change my mind on that one. I do think it's still more efficient time wise, because they're able to do it whatever office they're in. They're able to, providing there's privacy, they can make sure that they've got the camera up and that they can actually then participate in the group, as opposed to having to travel somewhere and actually be at a venue and be away from doing any other work. It probably just fits in a little better with their workflow in terms of completing other pieces of work. So they might, they would obviously have to focus on the video group clinic for the 90 minutes, but then they can immediately go on and do something else, as opposed to having to travel back to a venue. Not sure if you've got anything to add, Jan?
I think as well that the group setting, it can raise topics that if we were doing it on a one-to-one basis, the individual might not actually bring up because they might think it's not worth mentioning. However, in a group setting, they tend to spur one another on with ideas, both positive and also their concerns. And they can also support each other to know it's almost validating their experience. So I think that has, it improves things so that we can actually then act on what they're asking and hopefully support them to self-manage their fatigue. So having the group setting can often help us get to the bottom of the difficulty that they're experiencing. We can get straight to the matter and help them.
So within the video group clinics that we run, we have as the basis, the kind of initial part, is a patient recorded outcome measure, which has been validated to be used within cancer services, called MyCore. And it's My Concerns and Wellbeing. And it's a very simple tool, where you would actually ask the patient to rate their concern, and kind of their concern at the beginning on a scale of 0 to 6, and then what their overall well-being is as well. And they raise 2 concerns, so we would ask them to identify 2 concerns. Very simple, so we just want, kind of not too much depth. So what it may be to do with diet, it may be to do with sleep, and we then take that and we incorporate that within the first video group clinic session, in that goes onto our discussion board. So each of the patients that are going to attend the video group clinic have had this initial phone call. We've then completed the MyCore measure, asking them what are their 2 concerns that they would like to discuss. And as I say, that then gets transferred onto the discussion board, and it's then used as the prompt. Kind of, so if somebody has mentioned, concerns with sleep, it could then be offered out to the group, has anybody else had that concern? Or it may be that 2 or 3 people have actually identified the same concern. So that's really used as kind of the starting point to explore very much what matters to the patient. So we've really tried to keep this very patient-centered. It's not about our concerns as healthcare professionals. It's about what are their concerns in relation to fatigue. So Jeanne, I don't know if you want to add anything there.
Yeah, I mean, a couple of examples would be we had a patient who had felt that she'd been left in limbo as nobody had told her that she was actually cancer free, and then especially with feeling the levels of fatigue that she was experiencing, she was quite distressed with this. But from attending the group, she then was able to recognize that by setting like small goals to try and increase her activity levels and listening to her body and resting when necessary, and also speaking to her work colleagues, you know, to let them know that this is real and that she does need to rest at times and have recovery days that she needs. That was really important to her. The fatigue levels may not necessarily have changed from the outcome measure scores, but her I suppose her attitude towards managing it had, and we often see quite a change in how how they score themselves afterwards.
Yeah, we're in terms of collating evidence, we are kind of pulling together the both pre and post scores, and that's been a bit of a learning curve for us because we got in a little bit of a kind of how shall I say, mixed up really in terms of what we were actually measuring. And bear in mind, we're supporting patients with fatigue. I think we were initially asking too many questions. So we've learned to simplify it. And we realized that we needed any information that we gathered, needed to be meaningful for the patients, in that they needed to see that if we were asking them questions about certain things, how were we then going to give them coping strategies for the topics that they were raising? So we've now narrowed it down to a very simple numerical rating score in terms of the fatigue, which is pre and post. And we are keeping a database where we record that. And then in terms of the MyCore, the measures there, so again, it's pre and post attendance at the video group clinic, as to how they would rate their concerns, and then they're kind of in terms of their own well-being, so in terms of how they're now feeling at the end of the video group clinics. So we've got a pre and a post measure, and we're collating that, and then I do quite a lot of promotion across our health board, capturing that information to say this has been the impact. We've been able to say what are the concerns that have been raised, and we've been able to group them. So we're aware so far in terms of cancer-related fatigue, certainly physical activity, and fear about cancer returning. Those are big areas of concern. And concerns about such as returning to work. So we're able to categorize that. And then we have a measure, direct measure of the actual concern itself. So hopefully that will have reduced. And then in terms of their well-being, which we are obviously hoping that will have improved. And again, we've all got that. We now have that on a database, so that with each video group clinic, we're putting that into the database, so we can then pull from that, and we can then use it of evidence of the impact for the patients. And for us, it's about actually really sourcing some long-term funding for our service. So this has been quite an important way of having both quantitative, and then we've also got direct patient feedback. And that has been very important and powerful in capturing the impact of the actual video group clinics for us.
The psychosocial impact on the patients from having these group sessions, it was quite interesting, really, because obviously in a face-to-face group, people could share numbers and keep in contact, whereas over the video group clinics, we obviously have to follow data protection, so we can't be passing on information, of people. However, there was a lot of peer support within the group, and it was evident that sometimes they did want to continue beyond the group. So there would be things like sending recipes via the central our email, so that we could send them on to the other group participants, of healthier meals and things like that. They were very supportive of one another. And when anybody was having a particularly difficult time, the empathy and the support that was given was evident. And I think that was very helpful to the individual that was experiencing it, but also for the person that was giving it as well. You could see that they felt that their experiences were, I suppose, useful in some way to somebody else.
I'm very aware from patient feedback, one in particular who was very, very reluctant to attend a video group clinic, really would have preferred a face-to-face interaction. He then attended the video group clinic and was blown away with how much it helped him. And very interesting, because I was actually asking for feedback so that I could then go and take to across our cancer division to promote what we were doing. And I think 2 of the people that have attended the video group clinics have been very, very keen to actually give me feedback and given me permission then to share it much wider, which I think speaks volumes, really, particularly the one gentleman that was very resistant to the video group clinics. They've actually wanted me to actually record them and talking about their experience of the group, and within that, the video group clinic format. So that's actually been really quite powerful in that how much they've wanted to give back, and they've wanted to share what a positive experience it's been for them.
Working in the group clinic environment, for me, it has definitely been a learning experience with the technology side of things, and also then having to support, when we are doing the facilitating, then also having to, I suppose, bring the group together initially, and not managing group dynamics, because in a face-to-face setting we would have to do the same there, but online it can sometimes be difficult if somebody turns off their camera, or but we did say that they could turn the cameras off if they were feeling tired, because we did have to obviously look at how we could best support their needs with their fatigue, as well as running the group session. I think we've learned over time, really, how best to develop the groups, and I think we will continue to learn, just to make it as best as possible for the patients, and to ensure that we are using our clinical time effectively, and meeting the needs of the service as well. The impact of team working with colleagues, both across psychology and occupational therapy, we've been able to work together, planning obviously the sessions, and actually facilitating the groups. That has been interesting, and it's also been a learning curve for us as we develop it, and move forward with it. It's good to be able to spend that time and to learn together.
As a manager, trying to introduce something new can always be a challenge. My advice would be, have discussions right at the beginning with as many people as possible. Initially, I had some resistance and some reluctance, which was more about trying a new way of working. And I would really recommend suggesting to people that they just give it a go initially. and that not kind of forcing it on them and saying, this is what we've got to do, and this is the way we've got to do it. My approach was very much, I thought it had potential, but I wasn't sure. And I was honest about that. And I just said, I wonder whether this is something we should try. And it was about being open and saying, let's start, a trial period of it. If it doesn't work, we will review it, we will change it. And if it's not the thing for us, then we will look at something else. So it was very much about collaborating and getting their initial interest, but also being honest and saying that we have some flexibility. I'm aware that when we initially started, the processes seemed very complicated, and there was some concern about the level of paperwork and kind of how the processes seemed quite complex. And it was very much about saying, well, and with the support of the team that guided us, you know, being honest and saying, well, we can adapt things. So really, it's not to be too rigid. It's get their initial interest, trial it, and then make sure you review it at the end of that trial. That would probably be my advice.
I think some of the top tips that, as a clinician and facilitator, I would say make sure that you have got the templates saved that for everything, even for the email invitations to the group settings. Check the attendance prior to them actually joining. So make sure that if you've sent out the invitation a week or two in advance, either a phone call or another email to check within the week of the video group clinic, just to remind them to attend, and also to focus on their concerns and to be flexible with the format of the discussions as well, because it should be patient-led, the discussion side of it.